Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. In this episode, Dr. Mansoor Mirza from the Copenhagen University Hospital in Denmark and Dr. Ana Oaknin from the Vall Institute of Oncology in Barcelona, Spain, will be discussing the current molecular classification of endometrial cancer and how it guides therapeutic decisions. This episode is part of a larger educational program entitled Advances in Endometrial Cancer Therapy, Exploring the Role of Immunotherapy. For more information on Dr. Mirza and Dr. Oaknin, along with a link to the complete program, including a downloadable slide set, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
Hello, thank you for joining this podcast. Today we are going to discuss between my good friend Mansoor Mirza and myself about endometrial cancer. Let me introduce Mansoor to you all. Mansoor is a very well-known key opinion leader in the field of gynecological malignancy. He's based in Denmark and he's the chair for NSGO group. And in addition, I think now, Mansoor, you are starting your term as chair of ENGO. Is it right?
That's correct. Thank you.
Excellent. So let me introduce myself. My name is Ana Oaknin. I'm here in the Gynecological Cancer Program at Vall Institute of Oncology in Barcelona, and I'm co-chair for the GEICO group in Spain. So let's start to discuss and to see how we are evolving in the field of endometrial cancer, because we are living a very, very exciting time. Now, we are modifying the way of classifying the endometrial cancer. So please, Mansoor, share with us about the molecular classification of endometrial cancer.
Well, thanks, Anna. First of all, it's a great pleasure always discussing these things among friends. With you, and I think the best thing we have seen in years in endometrial cancer was the paper in Nature in 2013 by Getz et al. About the TCGA endometrial cancer, showing that this is not just one disease when you look at the Cancer Genome Atlas data, and that was the beginning of understanding. How different are these tumors? So what that classification told us that they classified into four major subgroups, the whole endometrial cancer patient population. They put them into polymutated, that was one, that is also called ultramutated group. And then the other group was microsatellite unstable, hypermutated, and we will discuss later that these are the probably two groups where you will have really good benefit of immune therapy. But that's we will talk about how we can use this classification. And then the two other groups were copy number low, so-called endometrioid group, and copy number high as serous. So how we can, put it into those old days, type 1 and type 2. If you look at the different sort of mutations and put it into the old histological classification, I would say that if you look at endometrioid, about 1/3 of endometrioid patients will be ultramutated, and another 1/3 of the population is probably MSI high, and then you have copy number low. For the serous, most of these patients are copy number high, and then you have those carcinosarcomas in clear cell. But this TCGA subtypes started pushing us to discuss more about mutational load, about the grades and how we are going to use it, and adding other abnormalities like PI3K alterations, P53 mutations, KRAS mutations, HER2, and all those. And that has actually changed the whole way we are working today. And after the TCGA, we have actually made it possible to understand endometrial cancer much better.
Excellent. I mean, as per your explanation, it seems that we are getting into a new era in endometrial cancer. This new classification may lead us to a much more personalized medicine for our patients. So, in your opinion, do you think that this classification should or must be implemented in the clinic? And in addition, which biomarker we need to guide us in the treatment strategies? Please give us your opinion on this.
And absolutely. First of all, my answer to my first question is yes, absolutely. We should implement this molecular classification in our daily practice. We have, they will be published both the ESMO guidelines, which you are leading actually, and thanks. And it's going to be a great paper, which will be coming
out. Thank you.
And we will also have the ESMO Estro guidelines, and both of them have clearly strongly suggested to implement the molecular classification in our clinic. And that brings us to the next question. If you do that, and if you really want to use these classification, what are the minimal biomarkers we need to know to use this classification into clinic? And I'm sure you will agree that some of the biomarkers are those which will tell us that patients' tumors are actually very good prognosis. That's typically polymutated. So it's a difficult test for many clinics, but I think we have to work hard to convince our pathologists to work on it and have the polymutated mutation data available for our patients, especially in the early stage disease. Because in early stage disease, where in the countries where patients usually get adjuvant treatment, both radiation therapy and chemotherapy, maybe they can be definitely spared from that treatment, because there is a lot of data emerging showing that polymutated are very good prognosis patients. I would say that P53 mutation is something we must ask pathologists to report us. P53 mutation will be guiding us if this patient is in a bad prognosis and needs systemic therapy, needs chemotherapy. So that's another important molecular biomarker. Third biomarker, which is sometimes reported, sometimes not, is the estrogen receptor status. And that will also guide us what kind of treatment we are going to give, if patients will benefit from endocrine therapy more than the other patients. And last but not least, we must have for all patients the status of MSI, and because already now we have immune therapy available, and MSI status is necessary to find out how we are going to treat and what kind of treatment, what kind of, if we are going to use immune therapy, how we are going to use immune therapy as single agent or doublet. So I think it is alpha omega today to convince our pathologists in all institutions to perform minimally these 4 tests when the patient is diagnosed with endometrial cancer. Definitely we have to do many other ALCOM and all that, but if we can get that as the basis, I think we have achieved a lot in the first year or 2. I hope you will agree, Anna.
For sure. I fully agree with you. It's the only way to move forward with our patient diagnosed with endometrial cancer. It's the only way to improve our outcome, because with this new molecular classification, we will be able, to to reduce, because the treatment, I mean, some patients are over-treated and another patients are under-treated. So we will be able to tailor the treatment for our patient. So my other question that I had in mind, and I think you have almost addressed, is that if you think that we need to know the status of the molecular classification to determine who patients may benefit most of the immunotherapy. Do you think that we need to have this classification, or we may offer immunotherapy for all of our patients diagnosed with endometrial cancer?
That's another important thing, as you said. That I think we have to know the MSI status, MMR status of these patients, if they're molecular, the satellite unstable, or they are not. If possible, I would not press the pathologist, but if possible, we should know the status of a mutation load as well, TMB. But I think these are the things which will tell us if patient has a very high chance to have response to immune therapy as single agent. We are talking about single agent immune therapy or not. If they are MSS, if they're stable, if they're not MSI high, unstable, then if they're stable disease, then they do not have that high chance of response to immune therapy. So it's important that we separate these patients into two subgroups, MSI high and MSS. So MSI high, definitely we should have immune therapy available as a single agent to these patients. And when it comes to MSS, I believe that yes, there is data which shows that single agent activity is there, but it's a sort of modest. And there we really need to do some more work, and it has been done and it is being showed to add some other targeted agents which would maybe enhance the activity of immune therapy. For example, the small molecules like TKIs or PARP or other molecules. So yes, we need to know the status of MSI before we can tailor the therapy, immune therapy for our patients. Definitely.
Thank you so much. I mean, you and me, we are on the same page related with this biomarker to know what is the best therapy for our patients. So, I mean, would you be able to provide in a brief manner the name of some clinical trial where our audience could look for the emerging data that we have right now with immunotherapy in this disease?
So first of all, we don't have any results of any randomized trials. So the trials are phase 2 single agent trials, and the efficacy is seen both in the response rates and duration of response and disease control rate. And on top of that, the progression-free survival. I think the largest trial, which is done especially also in the MSI high group, is a Garnet trial, which Anna, you were the lead PI for, which has dostarlimab in that, and it has shown amazing response rates and even more strongly the disease control rate. Why I'm thinking about disease control rate? Because these are the patients who don't have any much other things to offer. So if your patient can be kept on treatment without progression for a longer time, it would be great. And the data were amazing. About almost 60% of the patients had a long disease control rate. So dostarlimab is definitely a very clear benefit drug. In the same trial, if you look, there was a huge number of patients in the MMR proficient, so-called MSS disease, and even there was quite nice response rate with immune therapy. But in that population, we have another trial presented by Vicky Marker in combination of pembrolizumab and lenvatinib, which has shown impressive response rates of 37%. So I think we have both for the trials available now with quite strong evidence of efficacy in MSS and MSI high population. So I think these are the two major trials which I would say are very important to lead us to treat our patients.
I mean, thank you. This is amazing. I think you have already provided to our audience with the key points in order to understand better the endometrial cancer disease and what is most important, the guide to treat in a better way of our patient with endometrial cancer. Thank you so much. It has been great to talk to you.
It was great talking to you as always, Anna. And I hope that we will see a change in the management of our patients, and we will change the landscape of treatment with this molecular classification being used practically, by using this in clinical trials to find more and more interesting agents and combinations. So I think we are living in a very, very privileged era where we have these possibilities which we can go ahead with our clinical trials and find better drugs for our patients. Thanks, Anna.
Excellent. Thank you. My pleasure.
Thank you very much, Dr. Mirza and Dr. Oaknin, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Advances in Endometrial Cancer Therapy, Exploring the Role of Immunotherapy, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.